Welcome to today's webinar presented by SAMHSA's Gain Center with the support of SAMHSA, which is the Substance Abuse and Mental Health Services Administration. Today's webinar is part one of our virtual learning community on early diversion and is titled Strategies for Addressing Treatment Engagement Challenges with Certain Individuals. The two presenters today are Steve Miccio and Mark Giuliano, and I will present them and introduce them shortly. I am Michelle Saunders, licensed clinical social worker, and I am a senior consultant with Policy Research Associates. I will be your moderator and facilitator of today's webinar. Before we start our presentation, I have some housekeeping items to review. The views, opinions, and content expressed in this presentation and discussion do not necessarily reflect the views, opinions, or policies of the Center for Mental Health Services, the Center for Substance Abuse Treatment, the Substance Abuse and Mental Health Services Administration, or the U.S. Department of Health and Human Services. If you have any questions for the presenters or regarding the technology, please type them into the Q&A pod on the right of your screen. We will address as many of your questions to the presenters as time permits during the discussion group following this presentation. We will also be conducting a couple of polls and appreciate your participation. When you see a poll pop up on your screen, please enter your responses. This webinar is being recorded and slides will be disseminated via the Gains listserv following the webinar. We will also notify you when the webinar recording is posted on SAMHSA's YouTube channel. A certificate of attendance will be available for download at the end of the webinar. Please note this certificate is for personal portfolio use only and is not for continuing education credits. There is American Sign Language interpretation for this event. To view ASL interpretation, go to Layout in the upper right-hand corner of the screen. Then select Hide Non-Video Participants, and then change the layout view to full screen. Finally, select View All. This icon looks like opposing edges of a rectangle. The interpreters for today are Dave Gratzer and Catherine Lambie. There is also live captioning for this event. To view live captioning, select the Accept button in the multimedia pod located in the lower right-hand corner of your WebEx screen. The color contrast of the live caption pod can be changed as needed. The high contrast style is recommended for best visibility. And next, I'd like to introduce today's webinar agenda. Coming up next is Roxanne Castanedo, who will give some comments from SAMHSA, and then I will introduce our presenters. And now I'd like to turn this over to Roxanne Castanedo, who is the Public Health Advisor at the Substance Abuse Mental Health Services Administration, for some opening remarks. Roxanne?
To the Gain Center for Criminal Justice Projects. I want to take a moment to thank the Gain Center, particularly Dan Abreu, Michelle Saunders, and Sam Rogers for their excellent work at developing this event. In an article written by Dixon, Holishitz, and Nazel on treatment engagement, they state that numerous variables may affect level of treatment engagement, including therapeutic alliance, accessibility of care, and the client's trust that the treatment will address his or her own unique goals. Individuals living with serious mental illness are often difficult to engage in ongoing treatment with high dropout rates. Poor engagement may lead to exacerbation of symptoms, rehospitalization, possible arrest, and incarceration. They further write that there is not a one-size-fits-all approach, as engagement occurs in the context of an individual's unique personality, social and life circumstances, and symptom burden. Treatment engagement remains one of the primary barriers for the person with serious mental illness, substance use disorder, someone who is in crisis, possibly homeless, and facing possible arrest and incarceration. We welcome learning from our experts, Steve Mizio and Mark Giuliano today. Michelle?
Thank you, Roxanne. Today's presentation is part one of the Gain Center's 5-part virtual learning community on early diversion. Here are the remaining webinars in this series. There will be information coming out on all of these, so we hope you will join for all the different learning communities on early diversion. And now I'd like to introduce our 2 speakers for today's presentation. First is Steve Mizio, who is the CEO of People USA, a peer-run behavioral health organization headquartered in Poughkeepsie, New York. Steve has been instrumental in developing several innovative programs that integrate the expertise of peers, and he's also created changes to treatment environments that are more welcoming and promote better recovery. Steve developed the Rose House model, which provides peer-operated crisis respite as an alternative to psychiatric hospitals and emergency rooms. He also developed the world's first peer-run crisis stabilization center and the first one in the northeastern United States. Steve has also been an active and valuable training member for CIT programs throughout New York. We are also joined by Mark Giuliano, who is the Program Director of Community Support for Westchester County Department of Community Mental Health. Mark oversees outreach and care coordination services for people with mental health concerns and co-occurring disorders who are justice involved. Mark has developed many programs aimed at addressing diversion alternatives from the criminal justice system, and he too has been a valuable part of the CIT program in Westchester County as their CIT coordinator. Mark is also a master trainer and consultant who lends his experience and expertise for system improvements. As we get ready for today's presentation, I'd like to share I think we've got a poll going on. So if you could take a minute to answer the poll, I will share some of those results at a later time to let folks know where everybody's come from. So at this point in time, I'd like to turn this over to Steve Mizio and Mark Giuliano to begin the presentation.
All right, thank you. Mark, you want to take it?
Sure. So I wanted to thank first everyone at Policy Research Associates, the Gain Center, and SAMHSA for having us today. This is an area that both Steve and I are really quite passionate about, and we are really excited about the opportunity to begin to talk about early diversion efforts and how we might be able to engage people in services that are going to be meaningful for their recovery. So I originally learned a bit about the sequential intercept model quite some time ago, directly through the staff at Policy Research Associates, and I'm hopeful that most of the people on this call or on this webinar are familiar with the sequential intercept model. When I first learned about it, I learned about it from Hank Stedman, who said that when we take a look at the justice system, it's a people processing system. And people come in contact with law enforcement and the courts, and they're processed through the system. But at the same time, there's an opportunity for this to be a point of change for people, or a people changing system. I believe, interestingly, that my co-presenter today, when I first learned about the sequential intercept model, it started at intercept 1. And when we began to talk about some of the preventive types of services and crisis services that might be available in the community, Steve said something to the effect of, what we're really talking about is intercept 0. And that expanded the sequential intercept model out just that much further. So we're going to focus today on the first 2 intercepts within the sequential intercept model, recognizing that there may be much more along the way. So with my with the work that I've done, not with the Department of Community Mental Health, but with the New York State Institute for Police Mental Health and Community Collaboration, I've had the opportunity to go into close to 30 counties within New York State to take a look at their crisis services with my colleague Don Kamen. And as we've taken a look at many of the crisis services, it's given us sort of a deep dive, if you will, into Intercept 0 and Intercept 1. I want to take an opportunity to tell you that I've learned as much from each of those sites and in the other communities that I've done some consulting for outside of New York State. I've learned as much from the process as anyone else. And I've tried to take many of the things that I've learned and implement them within our own community. So we're going to focus today on Intercept 0 and a little bit into Intercept 1. The rest of the webinar series, or the community learning series, will then begin to capture some of the other interventions at other intercepts within the sequential intercept model. Move to the next slide.
Thanks, Mark. And I too would like to thank everyone for this opportunity to speak. And I love how Mark put it, that it's what we learn and what we can bring back to our communities that really helps us to create a better vision and a better system of care in our own communities. And it has been a great learning process in working with Mark and with PRA and all the other folks that we've been fortunate to work with over the years. I just want to give you an idea of what we have on our plates right now as far as mental health issues and substance use issues in America. Our jail populations, as many of you know, are exceeding capacity on dealing with people with mental health issues and co-occurring issues in our jails, and they've really trans-institutionalized into our new behavioral health systems over the years. And I think that's why we're here today, is to really talk about how do we make the difference? How do we make the changes that are important in our communities? Next slide. So this is just an example of our local community and what we're dealing with. And I will say that it's really, these numbers are really a snapshot, because on any given day, those numbers could be higher or lower. For any community that you're working in, or any jail you're working in, any hospital you're working in, but the numbers are high, and you see that the number of visits, emergency room visits, are very high. Numbers of discharges, again, high. So are people getting the care they need, or are they getting discharged and back on the streets only to commit a crime or commit misdemeanors or something that's going to get them and move them into the criminal justice system? And this is something that I took notice of when I started in my position 21 years ago, and attempted to make a change and make a shift in our criminal justice to mostly avoid the criminal justice system. Made sense to me, and that's why I talked about Intercept 0. Sometimes I even now talk about Intercept -1 at some point. A deeper discussion. Next slide. So you can see what's driving the high utilization is substance use, and then number 3 down is psychological in our top admission conditions, and people call them all different names, high utilizers. I don't like a lot of the names that are used, unfortunately, but these are folks that will use the system repeatedly, and there's that brings to mind an issue of something that's not working for the individual. And a lot of times you hear people say, well, it's the complexity of the people we serve. And I turn it around and say, it's the complexity of the system we designed that makes it difficult for people to move into a better recovery and a better quality of life for themselves. So I keep that in mind with everything that I do in my services that I create, that you want to keep it uncomplicated. You want to keep it simple and accessible and efficient and effective. But most of all, you want to keep it recovery focused. And how do you do that? It's through a series of services that we're going to talk about today. Mark?
It's interesting that you say that, Steve, because We're in the midst of running a CIT class in Westchester right now. And one of the things that I said as we brought some of our service providers in, and we were talking about the system of mental health services within our particular community. I said that the first 9 years of my position at the Department of Community Mental Health, I worked in developmental disability services, serving people with developmental disabilities. I jumped the fence about 21 years ago into working with people with serious mental health concerns as well as co-occurring disorders. And when I jumped the fence into adult mental health services, I said to myself, I thank God every day that I don't have a very serious mental health condition, because the system is confusing. It's often fragmented, it's often uninviting, and even for someone who is a professional in the field, it was really difficult to figure out how to access the right services to help people move forward within their recovery. So I think you're absolutely right when it comes, when you say that we need to keep it simple for people and make it as accessible as possible, because the system can often be uninviting. Let's move to the next slide. So one of the things that we began to take a look at over the times that we've provided some of that intensive system mapping within 0 in 1, or Intercept 0 in 1, we began to look at some of the pre-crisis prevention interventions that we might be able to have. So if I were to take a step back, when we begin to look at Intercept 0, we're often looking at what community crisis interventions are available, but we even have to take a step back further and look at the community awareness. And what are we doing in order to destigmatize the issues around reaching out for mental health care? Obviously, there's been a shift in the need for mental health care with the current COVID health crisis. And it seems to be something that people are much more able to recognize that there may be a need for mental health services. But prior to that, what were we doing as communities to promote anti-stigma efforts and make sure that we had credible gatekeepers throughout the community to provide suicide prevention efforts and raise the awareness of community education and supportive services to make the system as simple as possible and make it accessible and make it okay to talk about what it's like to live with a mental health concern or co-occurring disorder. Let's move to the next slide. One of the other things that we noticed within our community, and I'm not speaking about the system mapping that we've done in some of the communities throughout New York State, but what I found is that when people go into mental health crisis, it oftentimes, if not most of the time, has very little to do with their mental health concerns. What it has to do with more often than not is an inability to put a meal in their stomach, an inability to put a roof over their head, an inability to access the critical services that are out there. We had an opportunity some time ago to embed one of our mental health workers, our outreach workers, into our local Department of Social Services. The Department of Social Services was anxious because they weren't sure that they were well enough equipped to work with somebody who's experiencing the crises that people often present with when they come into the Department of Social Services. So they were welcoming and they wanted us there. And we took that opportunity to create a bridge between the mental health system and the social service system so that people had easier access to the critical supports and services that they might need. We also realized in our community that many of the people that we struggled with and were having a difficult time engaging with were people who were living on the streets. They were living in places that weren't meant for human habitation. And we realized that we needed to take a concerted effort into reaching out to people and triaging them to see where they fit within the system. Going along with some of the public education and information that's out there, we took an opportunity to also embed clinicians into many of the major schools within the school system, so that youth within our system of care would have access to school-based mental health services. We also recognize the importance of organizations like the National Alliance for Mental Illness. When I've gone to any community to talk about mental health services and to talk about how to access the appropriate services, the very first place that I visit is the NAMI website, because family members often know the services that are truly effective and those that are going to be able to support people with lived experience and people with and family members with lived experience. And other family support programs can be critical and imperative in helping a person with their recovery. If we want to truly help people recover, we have to have the family on board to create that safety net and that social network for the individual. We know that many of the people that we work with, they burn the bridges in many respects with family members and other supportive people within their life, and to try to help rebuild that safety net can be critical. And we also recognize that there's an importance in having people reach out to warm lines as opposed to taking a look at every telephone call being a crisis telephone call. Sometimes people just need that connection and they just need the support. This is the first bullet up here is one of the things that's really come to light and has become operationalized pretty quickly, at least in New York State, where we began to co-locate mental health personnel within our health clinics. We've had that for years and years, but knowing the devastation and the traumatic traumatic incidents that people are experiencing due to our current health crisis has become more important than ever. We recognize that there are some people with intellectual and developmental disabilities that are also going to need crisis support. So it becomes incumbent upon us who are creating this crisis system to be as inclusive as possible. We're going to speak a little bit about scheduled respite services. We're not going to call them respite services. I believe if it turned out that today I were to make a reservation at the Rose House, which Steve will speak a bit about, I would be referred to as a guest. Respite services sounds stigmatizing in and of itself. And we also have to have that accessibility to the traditional services that are out there. But one of the things that I really learned from many of the people that work with me, and I've got about 21 people that work within our outreach and care coordination unit. The vast majority of the people that are in our unit, it's funny, Steve and I are both a couple of white guys, but most of the people that work in my unit reflect the people that live in the community. 70% of the people that I have that work for me are people of color. There's a smaller percentage of them who are bilingual and Spanish speaking. And one of the things that I learned from them really quickly was the importance of clergy and faith-based supports. Knowing how to get people connected with services through their pastor or through their imam or through those other faith-based supports that are available there in the community. It's something that from my particular position within the world, I would not have even considered, but I came to realize over the time that I've been doing this, that many people, especially people of color, when they reach out for mental health support, they're reaching out to their clergy and they're reaching out to other faith-based supports that would be critical in their recovery. Obviously, if it turned out that we were going to set up a crisis response system, we would have to have a crisis hotline and mobile crisis teams. But it's interesting, if you go across the state of New York and you go across the country, that there's tremendous variability in the hours that crisis hotlines work and the availability of mobile crisis teams. Recently, we've begun to work with Steve's organization, People USA, on developing a 911 diversion model within our community, because we want to look at this almost from a risk responsivity approach, where if we've got a mental health crisis that doesn't pose a high risk, we want to divert that and have a mental health response. And if it turned out that I were to come into your community or you were to come into mine, we'd want to be able to take a look to see if people have the opportunity to simply walk into a clinic for a crisis appointment, take stock and inventory as to whether there are crisis stabilization centers or crisis stabilization services, including respite, living room models, and other crisis supports. obviously the one of the long-term backbones of many crisis service systems is the inpatient hospital care. But we also want to have the opportunity to reach out to people who may be struggling with co-occurring disorders using that substance use outreach because of the fact that many of the people that we have very complex needs that are punctuated not only by their mental health concerns, but substance use issues and long histories of trauma. And we need to be sensitive to integrate all of those services together to help people move on with their recovery. Let's move to the next one. Okay, it's our early diversions moving into our law enforcement-based programs. There are programs like LEAD, or the Law Enforcement Assisted Diversion Program, which primarily focuses on substance use. And in some respects, I don't see their mission as being that much different than our crisis intervention team models. As I said, we're in the midst of a 40-hour crisis intervention team. We've been delivering CIT training within our community since 2006. We've had hundreds of officers trained, and if it turned out that it were my family member or if it were me that went into a state of emotional or behavioral health crisis or mental health crisis, I want to make sure that the person that responds is well trained on how to manage the issues that I'm presenting. We, in our community, we've taken the opportunity to develop some police mental health co-response models. Sadly, our first police co-response model was not built out of innovation, but it was built out of innovation which was precipitated by necessity when we had a horrific tragedy of a person who had been murdered by a person who had been released from prison. And oddly, the person who had been released from prison had not, I wouldn't consider him someone to have a serious mental health concern, but he was definitely in a state of emotional crisis on the day that the murder occurred. What we realized pretty quickly is that we needed to create a co-response to reach out to people, not only from a law enforcement perspective, but a mental health perspective. And I took one of my workers and I said, okay, you're going to sit over at the White Plains Police Department. And she said, you want me to do what? And I said, you're going to co-response on call. You're going to have a co-response on calls. It's going to be really cool. And she said, you want me to do what? And eventually it morphed into a pretty phenomenal co-response model that we've developed in multiple police agencies throughout our community. We're looking at, as many communities are, those other types of behavioral health response models, including pairing up mental health workers with EMS personnel to reach out to people who might be in that state of crisis. Move to the next slide. So if we're going to engage people, the first thing we have to do is we have to be welcoming. We have to be welcoming in the way we approach them, in the tone of our voice. We have to be understanding and welcoming in the look within our eyes. Remember, many people that we have that have been in the mental health system and in the substance use system, and people who are living in places that are meant for human habitation, they've experienced tremendous trauma within their life. And they become masters of observation. They pick up subtle cues of the environment. And they're watching us and assessing us as much as we are assessing them when we're trying to do our initial intervention. And we have to communicate in a variety of ways, not just through our words, but through the tone of our voice and through our body language, that we're welcoming and that we welcome them with unconditional positive regard to help them move forward in recovery-focused services that are meaningful to them. Our efforts have to be assertive. We recognize that many times the people that we have, it's not just a one and done. We have to go back out time and time again to really continuously re-engage and reassure the person that we're there to help. We want to use motivational interviewing techniques within our assertive intervention. So our intervention should always be infused with motivational interviewing, because that's what helps people make change. People are going to make change because they believe that the change is important to them, and they believe that they've got the ability to do it. And when we partner with them through our assertive outreach, many times we're beginning to support their self-efficacy. In using our motivational interview, we can help that person make change that's meaningful for them. Those services that we offer, they have to be recovery focused. And as I said a moment ago, it also has to be trauma informed, because the prevalence of trauma in the groups of people that we work with is just overwhelming. We have to understand where people have come from, and we have to understand what they've lived through. Not what's wrong with them today, but what they've lived through over the course of their life. And then finally, our services, well, not finally, we have the cultural competent as well. But one of the other really important pieces of this puzzle is that we know that motivational interviewing is based on the wisdom of the person, and our services need to be person-centered. We need to understand what it is that the person wants. Our treatment plans, our interventions, our outreach efforts, they can't be cookie cutter approaches to people. We have to listen and truly listen to what's meaningful for that person to help them move forward with their recovery. And sometimes they don't want to talk about the things that appear to be important to us. We may think that it's important for them to stop using alcohol and other drugs, but what they really want to talk about is the fact that they've got a son or a daughter that they're having a difficult time getting custody back of. So what we need to be able to do is use their importance of having their custody of their child back in a way that motivates them to make change on the substance use side of the fence. We had an opportunity to develop our care coordination program from a truly person-centered approach, and it worked wonders. We had a gentleman who was living in the city of New Rochelle. He was homeless. He was renting the back seat of a van. That's where he was sleeping. And when we sat down with him and we asked him what was really meaningful for him, and tell us a little bit about those things that you're truly proud of and those things that you've accomplished, he began to talk about the fact that he had been in a salsa rock band in the 1970s, and he was really a very accomplished trumpet player. So we used some of our dollars, service dollars, for non-traditional types of supports, and we bought him a trumpet. And it was that piece of the puzzle was so meaningful for him, we were able to eventually get him off the streets and get him on a good track with recovery. And finally, as I said before, we have to be culturally competent in the services that we deliver. Culturally competent means a number of different things, of course. And I don't see cultural competence as simply being a matter of race or a matter of ethnicity. We have to be culturally competent in many other respects. Odds are, just by the mere fact that I live outside the New York City metropolitan area, some of you may think that that I'm in a manic phase of bipolar disorder because I'm speaking as quickly as I'm speaking. The fact of the matter is, we speak more quickly outside of the New York City area. In many major metropolitan areas, people tend to speak more quickly. So there's those subtle innuendos that are there within our ability to assess people and understand where they're coming from so that we can be culturally competent. We have to be culturally competent to understand how people have survived as long as they have, living on the streets in places that aren't meant for human habitation. We have to be culturally competent to understand what people have lived through during periods of incarceration. We have to be culturally competent across the board so that we can really understand where people are coming from and help them move on forward with their recovery. Let's move to the next slide. So some of the things that we've highlighted over the past little while are some of the interventions that we have within our communities. And Steve and I actually work pretty closely together, despite the fact that we work in different counties. We've begun to collaborate on some of the projects that we have in both Duchess County and in Westchester County. So as I said to you before, one of the real luxuries of being able to go into other communities, into your communities, and see what's happening is I like to steal little pieces of the puzzle to try and shore up our own system, to make sure that we're doing everything that we can to assertively help people who are struggling with mental health crisis. So we've had the good fortune of being able to develop homeless outreach services, and a lot of that is funded through PATH funding. We have mobile crisis and with our crisis prevention response team. Steve's going to talk a bit about Rose House and the Stabilization Center. At Intercept One, we've got our CIT interventions and our police mental health outreach teams, as well as our mobile assessment, mobile access project, or initiative, I should say. One of the things that we know, you may not realize about Westchester County, is it's incredibly diverse. We've got very tightly populated cities, and we also have some rural areas of Westchester County as well. It's a pretty broad range of different types of communities. I'm certain that there are people on this webinar today who have much more phenomenal challenges when it comes to working in a rural community. But one of the ways that we've taken the opportunity to get mental health services out there to some of our communities that are a little bit more rural is by using the mobile access or mobile assessment program, assigning a mental health worker or peer to police departments, so that way when law enforcement is made contact with somebody, they've got other supports, either using an iPad or a computer, a laptop computer, or just simply over the phone, where we can assess what's going on with the individual. Steve, I'm sure, is going to speak a little bit further about the Stabilization Center. And I will tell you, at Intercept One and into Intercept Two, we've had the opportunity to collaborate and create the Crisis Stabilization Team, which is a law enforcement, actually a justice-involved diversion program. So the referrals that we receive are from the courts as well as from law enforcement, and we want to get in contact with people as quickly as possible so they don't go further into the justice system. And with that, we've used a data match system in order to identify people who have been fingerprinted by law enforcement, so that there's a notification to us at the county level that a person with mental health concerns has come in contact with law enforcement. And if we can use that as an opportunity to intervene before the person goes further into the justice system, we're that much better off. If it turns out that the person does go further into Intercept Two, we have our Alternative to Incarceration program and our mental health court, as well as a crisis stabilization team. So let's move to the next slide.
So let me tell you a little bit about People USA. We used to be called People Incorporated. We changed it to USA because we have just rebranded and gone more international with some of our work. We were established in 1990, and we are 100% peer run. I myself have been through the acute care hospital psychiatric system and years and years of dealing with a diagnosis of bipolar disorder and struggling with medication, as people call it, medication compliance or resistance, whatever you want to call it. And just had to, learn and find my own way to wellness. And I did find it through other people that were diagnosed similar to me and sharing those stories. And I found that's where my hope really started to infuse itself into me when I knew I wasn't alone anymore. And so this whole concept of peer supports became a passion of mine and very important to me. And that's when I, 21 years ago, learned about People Incorporated and joined in as their executive director at that point in my life. Since then, we were an advocacy organization. We still are an advocacy organization. But what I noticed was that it was easy to throw rocks at a system of care, but I felt it was more important to try to show how it could be done. And I started to work on getting funded in different areas, and that's where the Rose House came from. That's where putting people with lived experience into emergency departments and other mental health facilities came from, and I felt it was important to be there to advocate and help people get through things and not just throw rocks at a system that I felt wasn't working well. My experience wasn't the best. And you know, in my hospitalization, I went in as Steve Michio. I came out as a mental patient, and it didn't feel good. And I don't want people to have to feel that. And I never forget that every day that I come into work, that it's important to give people the dignity and the respect they deserve and the hope, and lending the vision of hope to people that may not be hopeful at that point in their life. So we have spread our unique models and work around the US and internationally now. So it's something that is working. It's not quite the evidence-based practice we'd like it to be, but it is practice-based evidence, which I think is just as important as evidence-based practices out there. Next slide. We worked from some core values that I recognized over the years of what was working. And one was the engagement. How do we value the person we're serving, the guests that we serve, or the people that we come into contact with day to day? The environments, do people feel safe where they go? And I, you know, I'd ask everyone to look at their environments where people are served and ask yourself, would I feel comfortable if I had a loved one coming in here? And if you would, that's great. We go through great lengths of creating environments internally and in community. We want to meet people in nice places when we're working with them. We want to meet people, or people to come to our facilities that are safe, that are comfortable, that are nice looking, and we, you know, it's very trauma informed. Everything we do is, and we're asking our guests constantly if they feel safe where we're serving them. The mutuality is a big piece of the secret that works for many of us, and that's the sharing of the similar experiences that we've had in our lives. It doesn't mean we've, you know, gone through the same experiences or done the same things as people, but I think having the lived experience of being diagnosed, going through a whole different treatment modality in our lives of different experiences is important. And if we can learn from that and share it and grow from those experiences, that's what really not only lends the vision of hope, it builds empowerment and self-determination in the people that we serve. And then the philosophy that people can find their own pathways to recovery and wellness is something we feel is really important, because so many of us have been told we're going to be diagnosed the rest of our life, we're going to be mentally ill the rest of our life, we're going to be in addiction services the rest of our life. And unfortunately, those words are still spoken today. And our philosophy is, well, we expect recovery. We expect you to do better for yourself, as long as you're open to be educated, to work with us, to build trust, and move along a path of maybe some different choices in wellness in moving forward. So it really is important and infused into all of our different services within our organization. Next slide. So this is keeping people out of the criminal justice system. And I think that's important. Even though a lot of us are doing the crisis intervention team training, a lot of us are involved in criminal justice councils and criminal justice systems, we're doing it because that's where the people we want to serve are. We're not doing it because we want people moving into those systems of care. And so I think it's important in the sequential intercept, you know, that we look at those, see where the gaps are, see what we can do as a community in creating a better quality of care and possibilities for the people we serve. The forensic mobile team is one of our teams that we're partnered in Westchester on, and they are a group of dynamic staff that care, that are compassionate. They work directly with the law enforcement and the courts. They ensure that people presenting with behavioral health issues stay out of the criminal justice system. Those staff are extremely busy, and Mark can tell you, they're just always hopping and going all over the county, trying to help people avoid the criminal justice system. And then there's the hybrid model, which I think Mark can talk a little bit about.
So with our hybrid model, that's our crisis response, once again, for people who have come in contact with law enforcement. And we do have people, we have in the Yonkers Police Department, I have a clinician embedded in the Yonkers Police Department. We have a clinician embedded in the New Rochelle Police Department, a licensed mental health counselor. In the White Plains Police Department, we have a social worker who's embedded. And in our, over in the Greenberg Police Department, up until just recently, one of the members of the Crisis Stabilization Team, one of the people employed by People USA, had been working to provide follow-up for people who are in a state of not only intervention at the time of crisis, but follow-up after the crisis, where we're working with that person to get connected with services so that the person doesn't have to come back in contact with law enforcement personnel. And you know, it's funny, as Steve was talking about mutuality, one of the things I've taken a look at over the years is that when I take a look at the people that we have that work for us, it's not just a matter of reflecting the community from a racial, ethnic perspective, but over half of my staff are people who have lived experience receiving mental health counseling or mental health interventions. About half of my staff have a history of lived experience with substance use. A smaller percentage of the people that I have that work in our unit are people who have had bouts with homelessness and interactions with the justice system. So in many respects, are the people that work in this program and are in our both of our programs, as well as our collaborative program, are people who have lived through the same experiences as the people that we're trying to engage. So we're not looking to approach people from that medical model approach. We're helping walk people to take a different path and a different choice within their life. So not everyone within my unit identifies as a recipient of services or a peer supporter. Most people don't. But the fact is that I had done an anonymous survey of my staff just to find out who had been through trauma, who had been through experienced homelessness, who had been incarcerated. And it was a large percentage of the people that work in our unit, as well as living with family members with substance use and mental health problems as well. Dan, I thought I saw in the chat there was some question about how our embedded personnel are funded. We thought it would make a lot of sense to blend some of our funding or braid some of our funding, because many of the people that we had are people who were living on the street. So we've taken a portion of our PATH funding and connected it with some of our local funding through the Department of Community Mental Health, so our tax levy dollars, and used it to create positions to reach out to people in the community. So it is a local investment, and I have an odd feeling that with police reform over the next little while, we may have some additional funding to do other types of initiatives. And I think that many of the communities across the United States are going to be in a very unique position to take some of the funding that's out there and use it as an opportunity to do better by people.
Hey, Mark, I'd like to also add, under the Medicaid redesign in New York, there's health homes in New York, which are care management has been renamed into under health homes, which is providing different case management services under that. And what we're finding and developing here is that we're finding Health Home Plus, which is an additional add-on to Health Home Services, is another possible funding tool that we're investigating right now to also fund some of these services.
Mm-hmm. So let's move on to the next slide. So the people that we have that are in our crisis stabilization team, we do have a team leader and a peer support specialist. We made sure that we took into consideration the impact on the family. So we wanted to make sure that we had a family support specialist, and our mental health counselor is actually somebody who has lived experiences as well. So the team takes an integration of traditional mental health professionals and family peer supporters to reach out to people within the community. I'm going to jump to the next slide because I know we want to talk about the Stabilization Center. We can just blow past when we pass these slides. That's less important than it is to talk about our other types of interventions. All right, there you go.
Okay, so really briefly, I'll talk about this. The transition of care is basically my staff meeting people either mostly in emergency rooms or in inpatient units, and getting to building a relationship within the inpatient setting, and agreeing to bring those people home, because as some people have heard me speak over the years, is discharge plans don't work. This makes the discharge plan work. When you have somebody working side by side with you and working with you on that discharge plan, working with you on moving forward past that crisis, past that uh, incarceration in the hospital, into a life of possibilities, your outcomes are much better. And my staff stick with folks in that service between 6 and 12 months, and we've seen tremendous outcomes and results because of that. Next slide. So you can see it's no ER visits after we've served them at 87.1%. And these are people that were termed high utilizers. Again, I don't like that term. And then 91%, 91.9, there were no readmissions. So it does work. It's proving to work, and it's getting better as we move forward and learn from it. Next slide. So the Rose houses are houses that are basically like a bed and breakfast, but you can be in crisis. You can be, your criteria for going to a Rose house could be suicidal, could be hearing voices, could be major depression, could be a lot of the things that bring people to hospital emergency rooms, but do not need the medical intervention. And what we found is that when people come to our Rose house, they don't need that intervention. They need to be listened to. They need to be asked the right questions of what can help them, what have they tried, what haven't they tried, and what can we help them design in going forward. They can stay at the houses between 5 and 7 days if they want. Right now, the houses are free for anyone in the public, and it will remain that. We're moving into a Medicaid model, but it will still remain free if people need it. The staff that work there are peers. They're highly trained, highly skilled. We created it in 2001, and I didn't really do it to save money, but when we looked at, over the years of running it and the 20 years that we've been, one house can save between 2.5 million actually, and up to $8 million a year per house, depending on how many beds I have in the house. To just give you an idea of the savings that can occur and how it also lends to keeping people out of hospitals. Next slide. This is a picture of one of our Rose houses in Walden. I think people would appreciate this more than a jail or more than a hospital setting compared to what hospital settings look like. And then I just want to talk about Imagine Duchess, where the Stabilization Center came from. We did an asset-based community development process, which was similar to SIM mapping, and it was getting all of the health and human service and social service providers together, and the chambers of commerce, and most of the people in our community, getting them together and using an appreciative inquiry process of getting people organized and to talk about our system of care and our community and what could we change as the leadership of our community. And out of that came a strategic plan on how to create a better integrated system of care, from criminal justice to hospitalization to homelessness to everything that we are talking about, the social determinants. And the Stabilization Center also came out of that. And that is a 24-hour facility that people can be there for 23 hours and 59 minutes. It's a very comfortable environment. It is peer run. We do have clinicians there as well. We have caseworkers there, and we have addiction specialists there. And it's really a wellness hub for people to come to. We assess what's going on with you in your life, what kind of experiences are you having, what's not working for you, and how can we get you to the service that's going to be the best service for you and our community within 24 hours. And that's what we do. We also do all the CIT training for the officers, and that has been a great response to helping officers have another resource to bring people to. And they just come to the center, they drop them off, they're back on the street again. They're not waiting. For the hospital system, they have to wait. To process people in a jail, they have to wait. This keeps the officers where they should be, which is out on their streets. Next slide. This is a picture of the center itself. Again, it's more comfortable. It's actually getting more comfortable as I'm speaking right now because we're renovating it right now. And it is going to look more like a Rose House model, which I think is important. Again, the environment's important. And so it comes down to the peer piece of it. Many of you are probably talking about infusing peers into your services. And I think it's important to do that, but with the right frame of mind on what those peers are actually going to do. When I worked in the New York City in the parachute program, they were infusing peers into mobile teams and they were building respites. And what I noticed was they were happy to have peers on their teams, but they didn't know what the peers were capable of or what they were going to do. So what I did is I took that and I took everybody's job description on the mobile team, from the psychiatrist to the peer and everyone in between, and created a chart of everyone's job description, everyone's expectations, and what everyone is going to be doing or is capable of doing on that team. That clarification in itself helped everyone understand how the team could better function together. So you really have to look at, what the impact of each of the disciplines that you're working with can do. You want to have clear goals and objectives and in your services. We have to create, and for the Rose houses, we have a detailed action plan outlining how objectives are met for individuals. Our budgets are important. We want to have a comprehensive budget. We don't want to just work on a shoestring. It's got to be a healthy budget. We get and identify various stakeholders in our community that we want to be engaged with that are going to help us. So in other words, for stabilization and Rose houses, if we want a service in the community to respond to us and work with us, we have to build that relationship. And that's what I'm constantly doing, is building and rebuilding the relationships and re-educating our community on what we're capable of doing, but what we need the community to also do in helping us. And then evaluating. We were a peer-run organization years ago, and our data was just how many people did we serve. Now it's become, what does our data actually tell us? What does it tell us, and how do we evaluate our results? And we've gotten more comprehensive in our evaluation. Are we, making a difference on the criminal justice system? Are we reducing officer injury when we do CIT training and we have this continuum of care that works better than it used to? Are we keeping people in our community safe? Are the outcomes of the work we're doing helping people have a better self-determined life of recovery rather than being married to a system for their entire life? And so that data is the data that we're capturing, and that data is helping us evolve our system of care so that we get better at everything we do. And I just want to go over some of the training. Next slide, for the training that we do for the peers we have. We do have a certification in New York for peers on the addiction side and on the mental health side, but we also added motivational interviewing and trauma-informed care and practice. We infuse psych rehab into all of our staff and educate them on the value of psych rehab and how to use that. Staff are trained in suicide intervention skills training. And then moral recognition therapy we offer to our staff. When we hear of a training that's going to help us to be better facilitators and better people to help the people we serve, we jump on it and we train our staff, and we're constantly in training mode, as well as developing our own training, because there was no respite book when I built the Rose houses, so I had to create that. So I think it also helps when you're developing the training, you're learning from the people that you're working with and training outside of your organization to help them do a better job so they don't make the mistakes that maybe we made in the beginning. And so I think we're really building an evidence-based practice quality of care here, but it still has a little ways to go. But these are the things that we looked at through our SIM model, through our intercepts, through our asset-based community development, and our relationships with one another, on asking ourselves the question, what can we do to make the difference that needs to be made? Because we do know there needs to be a difference in the quality of care in behavioral health, but sometimes we don't know what questions to ask. And I think when we ask, from a more personal, compassionate level, we can get the answers, and then we can work together and create something that's going to be helpful for our entire community. So with that, I think it brings us to some questions. And I think that Michelle is going to.
Yeah. So Steve and Mark, really want to thank you for a presentation that was so comprehensive, and provided some very good illustration of things that you've both worked with for creating engagement for people with mental health, substance use disorders, to help them, get better connected to services and supports and away from the criminal justice system. We are going to be doing question and answer shortly when we move into our discussion group. So we'll be moving into that shortly. But I want to first remind our participants, if you have not already, please type any questions you may have into the Q&A pod to the right of your screen, because we will be using that to provide questions for Steve and Mark to answer. I want to also just remind you that we already let you know there is a webinar attendance certificate. So if you're interested in downloading that for personal use, you can do that now. You should see a file transfer box pop up on your screen, and if under the file name, click the files you would like, and it should turn blue, and then the download button should turn a darker gray, and when you click on the download button, it will initiate the process to download the certificate directly to your computer. And you'll see our last poll for the day popping up as well. So if you'd like to provide any input and additional technical assistance or other areas where you would like related information, then please indicate that, because this information does get shared with SAMHSA. So though, for clarification, it looks like the poll that popped up is the demographics poll. So I don't know if that needs to be switched out.
Michelle, this is Sam Rogers from the Gain Center. My apologies. We decided not to go with that second poll because in the registration that folks submitted, they were able to indicate future topics of interest. So I thought I would launch the opening poll again, just for anybody who didn't get the opportunity to submit it, because we closed it relatively early on in the presentation.
Great. Okay, well, then the poll that's up, for those that didn't get a chance to identify where you're from and what area you best describes what you do or where you represented from, go ahead and take a moment and answer that. And then I'm going to finish up just a few other wrap-up items for this part of the webinar before we move into the discussion group. So we've already talked about the certificate of attendance. So I'd like to provide you with information on the next webinars that are hosted by the SAMHSA's Gain Center. You can see the list here that on April 16th, there's a webinar on competence to stand trial, national webinar series on risk assessment and management in the context of competency restoration. On April 20th, we have a webinar on medication-assisted treatment in drug courts, virtual learning community, and this webinar will be addressing the concerns of court staff about medication-assisted treatment. And then on April 22nd, we have our second early diversion learning community webinar, which will be on addressing the critical need for housing and strategies to overcome barriers to improve housing access. So registration information for these webinars will be shared via the Gains listserv. So please keep your eye out for that information, and we hope you can join us. Which then leads me to say that if you haven't signed up for the Gains listserv, then I encourage you to sign up. The link is on the screen, so just enter that link into your favorite web browser, and it will take you to a place to enter your information, and you can make sure you stay up to date with all of the Gains Center's activities. So again, I'd like to thank you for your participation in today's events. If you have any other questions or comments, the Gains Center's direct contact is here on the website, and you can go to samhsa.gov/gains-center, or there's the phone number listed to directly reach the Gains Center. If you'd like to stick around for the discussion group related to today's webinar, we encourage you to do this because we plan to have an ongoing conversation in more detail around engagement strategies, a chance to talk with Mark and Steve in more detail about things they're doing, and for you all to share some of the ideas that you may be doing in your communities that is helping to increase engagement with people that perhaps aren't easily to engage, or the system doesn't engage them very well. So again, thank you for those that will not be joining, but for those that will move into with the discussion group, we will begin to get started with our discussion. So again, I want to just thank Steve and Mark for quite a comprehensive presentation. And as I was listening, I was taking some notes to try to provide a framework as we move into the discussion, and highlight or summarize some of the things you all addressed. And I was quite struck by many things. And I think as we look at engagement challenges, and you mentioned it in your presentation, the idea that are we talking about people that are resistant to treatment, or treatment services that are resistant to individuals? And I think that's sort of the question that goes back and forth. And I really like the way you sort of changed the paradigm. I think at the beginning, talking about, we tend to say that we're working with people that have a lot of complex issues or problems, and to say, no, it's probably more that our systems are very complex, which is more what we need to be looking at, not so much lay it sort of at the feet of individuals. And I like the idea of changing the whole paradigm about not blaming the person or the system, as I think, Steve, you said, throwing rocks, but what do we need to look at that's going to work for all involved? Making the kinds of system changes that you all have been speaking of, as well as understanding people from where they're at, and starting with a person-first approach, a person-centered approach, and starting from where they're at. You talked a lot about outreach strategies for those that have difficulty coming in. You talked about that for the schools, for homeless populations, of course, training of law enforcement to increase compassion, empathy, for officers to be able to build rapport with people, which can, lead to breaking down barriers of mistrust or fear, and that can help get people engaged to services versus the criminal justice system. Talking about having persistence and patience, not giving up, and empowering your staff and peers, empowering them and training them so they have the competency and the confidence to, in the work they're doing. So those are some of the things I took away. I'm sure many have taken some additional things, but with that, I'd like to go ahead and start some questions. And so one question that came up, and Steve, this person asked, they were just sort of wondering what your reasons for treatment non-adherence was about, was wondering if your treatment non-adherence was lack of insight, or sort of what was that like for you? As you said, you had been through many of these things and had to find your way.
Yeah, it was A little bit of both, but it was mostly what the medications were doing to me. And they may have been helping calm my head down, in different ways or deal with my depression, but they were also making the rest of me feel terrible. And so it was a struggle every day. Even to get up every day was very difficult because I was so medicated or felt I was. And so I struggled with that. And when I did start to feel a little better, I was one of those folks that would go off of my uh, off of my medication. I feel like, okay, I think I can handle this. And so it's part of that lack of insight was I never replaced it with anything. I didn't look for wellness tools or develop any wellness tools for myself because I didn't know much about that. And when I learned that, then I could more easily get off my medications and work on a healthier lifestyle. And that's what got me to where I am.
Great. Thank you. So, a question came in. How can you explain how you produce anti-stigma practices in the community?
Yeah,
And
that's an ongoing. I think part of it was is getting out into the community and educating the community, which I'm constantly doing. We're constantly doing, um, and helping people understand that the perceptions of mental health and the perceptions of addiction are 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 generally not accurate, and so we through lived experience and through people talking about their experiences and meeting others and meeting family members that have had that issue within their families for years, and helping them understand that there are other ways and there are other groups of people that do have that perseverance and do have that compassion and the commitment to help their loved ones. And I think that helps a lot in moving forward. And the other piece of it is to every time I opened a service, whether it was a Rose House or the Stabilization Center, people feared the worst. They would say, well, what if someone tries to kill themselves? What if they cut themselves? What if they become violent? And I turn it around and tell people, what if they really love it here? What if they feel safe here? What if they feel that they have a place that they can finally go to that's going to help them? And so we have a different approach and different mindset, and I try to help people understand that.
In addition to that, one of the things that I know that it's almost by design in the way we deliver CIT within our communities. In the very beginning of our CIT classes, we have almost a very stigmatized view of people in crisis who have mental health concerns. You'll notice that I make sure that I don't even use the word client or patient. It's a person with a mental health concern or a person with lived experience, because I always want to include the person in it. By the time we get to day 2 of our training, even the most cynical officers realize that it's not just about those people out there in the community, it's about every single one of us. Every single person that's on this call, every single person that we encounter has mental health. If we interacted with another human being, we had a thought, we had an emotion, we've got mental health. Some have mental health that's a little bit worse, and some have mental health that's a little bit better than others. But this is about all of us, and that really is how I think we need to begin to promote our the anti-stigma platform. Is that this is not just about those people; this is about all of us.
you're right, and I think, Mark, that's an excellent point to make out. We had one of our attendees sort of share within that same frame. It's about this paradigm shift. If we can help people frame things differently, frame things not from a stigmatizing or a judgment. They mentioned that, in your presentations, you talked about not liking some of the terminology that people use, like frequent flyer or frequent user, but to change things to people that may have high utilization or high recidivism. Medication compliance, medication consistency, inconsistency. So again, I think we don't really know, see the impact, but words matter and words are very powerful. So I think it sounds like that can be really helpful through the anti-stigma campaign, but sort of throughout all levels of the work you all do and we all do, is it's about changing how we view things and how we frame things that can, I think, help people feel part of versus, you know, pushed away from. So I really like that. There was another question that went to what time frame from walk-in crisis to appointment with a mental health professional is attained. So again, I think looking at how quickly can someone be engaged from a walk-in to connecting with somebody.
If you're talking about the stabilization center, it's 24 hours or less. They'll be engaged.
Okay, so if someone walks in within 24 hours, they'll be engaged with somebody that can provide services and support. Okay, great.
With some of our police mental health outreach programs and the crisis stabilization team, we anticipate that the person will have a contact with either a peer or a person who is on the clinical side of the fence within 24 hours as well. And sometimes it's immediate as a person's going into a state of crisis, because we've got the clinician embedded with law enforcement. So we want to make the earliest intervention as possible, but we don't want it to last we don't want it to go on more than a 24-hour period.
Great. Okay. I've got a few questions here that are related to the Rose House. So let me kind of start with, so one person asked, so how do you gently discharge individuals from the Rose House and possibly avoid squatters?
You know, it's a term people have said, this place is too nice. Who would want to leave here? And it's through the relationship of the 1 to 7 days that they're at the house, of helping them understand that they can certainly come back at some other point in their life, but our goal is to help them live successfully in the community or where it is where they reside. And we haven't had any issue with people that have been squatters or anything like that in the 20 years we've been doing it.
Okay. And then how will Rose House change as you move to billable crisis resident services?
As far as the philosophy and the actions of the staff and everything, nothing will change. The only thing that'll change is that we'll be a little busier doing the Medicaid notes, which aren't too bad as we're seeing them come out of the State Office of Mental Health.
Okay. And how many staff do you have in the facility?
Usually 2 per shift. That's for the Rose House. For the Stabilization Center, there are normally 4 to 7, depending on time of day. And then the mobile team, we have 5 staff.
Okay. Would you be willing to share the job descriptions for the team?
Which team?
Well, they didn't specify, so I'm wondering if it's the crisis stabilization team.
Yeah, we'd share that. Sure.
Okay.
Without a problem.
And what's nice is all the participants will be able to get a copy of your presentation that will have your contact information. So we're going to encourage people to reach out to you for either more information or to engage in more conversation. And then another question is to clarify the embedded staff, are they employees of the mental health agency?
The people that we have that are embedded in the local police departments are employed by the local Westchester County Department of Community Mental Health, but they're co-located in the local police department. So as I said, I have a staff person who's employed by DCMH, but she reports to work at the New Rochelle Police Department. I have someone else who reports at the Yonkers Police Department within the 4th Precinct, but they're employees of our department. And it's kind of interesting because one of the things that we always have to be mindful of, we saw this way back in the Desert Storm conflicts, where you had reporters that were embedded in with military personnel that would become sympathetic to the plight of the military personnel. Not that they shouldn't have been, but you get the idea. Their view is less objective. We have to always be mindful to make sure that our personnel that are embedded within law enforcement are still focused on the concepts of a person-centered approach to recovery, because ultimately that's going to lead to lower instances of law enforcement involvement. But at the same time, when you're around a group of people that has one mindset, you may become less objective in your view within the context of the host agency.
Okay, great, thank you. So are there any Rose House models in Dallas, Texas?
Not yet. They've been inquiring, but not yet.
Okay, great. So the person that asked that, if you're from Texas, you want to reach out to Steve and his team. Sort of speaking of, you know, the Rose House, the crisis stabilization, the settings, you know, you talked about the importance of them being more welcoming and more home-like versus what might be, you know, more the institutional settings of residential or crisis units, etc. So for communities that are interested to make a shift to change their environments to be more welcoming and more home-like, but needing to use sort of within the existing structures they have, how might they be able to do this with unlimited budgets, or again, if they don't have a lot of funding, what might be some strategies they could do that could make their environments more welcoming, that would engage folks more, but they just don't have a lot of funding, or they can't start from scratch?
Yeah, you know, some of this we got through not only meeting our community provider system, but also meeting the chambers of commerce. We got them very involved in
Oh,
what we do and building the relationships, and a lot of donations came in through that. So that's one way, one place to start, is building those relationships with your local chamber or business council or whatever you have in your communities. And then the other is to we actually talk a lot with our state office of mental health, and we ask them for money sometimes, and sometimes they have it and sometimes they don't. So there's another avenue that we've been able to use to help us change the environments.
and I think you make an interesting point. We tend to think of our traditional funding partners, and yet there's a lot of non-traditional business entities and you know, other non-traditional funders out in communities that, you know, oftentimes you know, are very much engaged with these concerns for their community. So I like that idea of thinking about, you know, Chamber of Commerce and other folks. You know, you might look at the real estate industry and such. There might be some resources there. So
Yeah.
So there's a question here about any creative ideas for drug court or treatment court sanctions to encourage accountability during the COVID pandemic, when most courts aren't jailing for violations. So again, I know we're really focusing on early diversion. I think though with this type of question, if people are not perhaps or are having difficulty with the, you know, adhering or following through with sanctions, that could lead back into the criminal justice system. So what might be some ideas for those that work within a drug court to help with accountability, particularly if the jail, you know, being rearrested or placed in jail is not really an option, but we want to help people get better? Or any thoughts?
I would go with journaling, having people write essays and people do what they can to take on additional assignments. It could be anything from COVID safe community services to writing an essay about why the importance of living a sober lifestyle, to the impact that they may have had on other people and reflecting upon that. So additional assignments for the person. I recognize that many of the people that we that we have within our mental health courts and our drug courts, they may have a hard time doing those kinds of things. But if we use some of the principles of moral recognition therapy, sometimes they can help each other through the court. if one of the aspects of moral recognition therapy is that the person who's participating is going to help other people. So we might assign someone to provide some additional mentoring to another person within the court. There are a lot of creative ways to implement sanctions that are actually modeling pro-social behaviors.
So that's I think those are wonderful suggestions. So really it is about maybe looking at changing the types of sanctions that the individual has been asked to do to ones that promote connectedness, promote wellness, recovery, and you know, praise them and honor them for following through with things that, you know, maintain that connectedness and wellness. So I really like that. Thank you. So how do you engage families that have given up to do the limited options available to them due to confidentiality restrictions? So I think what this is saying is families that find that there's a lot of restrictions around confidentiality and therefore maybe not being able to be easily engaged with their loved one who might be an adult. How do we kind of reach to families to keep them engaged when they've sort of given up due to some of the limited options and confidentiality sort of keeping them perhaps less engaged?
I think that's one of the reasons that we thought having a family support specialist was so critical in the development of the crisis stabilization team. We know that if it turns out that I'm working with an individual by themselves, we can make a tremendous amount of progress. But everything that they work with me can fall to the wayside based on what happens within the context of their family. So we have to get the family on board and engage to the best of their ability, despite the fact that we know that there's going to be limits on confidentiality. So the family support specialist really has to help support the belief that the family can make a difference in that person's life, despite the fact that they don't feel that they have control over what's going on for the person.
Okay, thank you. So in your experience, is brain injury considered when discussing treatment and addressing challenging behaviors?
One thing I didn't mention is that our stabilization center is closely partnered with the FQHC, the Federally Qualified Health Center, so that we can have a whole health approach for people we serve. And when people come in, they do mostly a self-assessment on their health and their overall, behavioral health issues. But my staff are trained, and we have clinical staff there as well that are trained to recognize different things. And we have had people that have been dealing with traumatic brain injuries, where we've been able to get them connected either to the FQHC or to the appropriate medical staff that they need to be, engaged with.
And I would say on our side of the fence, it's interesting. In the beginning of the presentation, I alluded to the fact that I worked in developmental disabilities at the Department of Mental Health for 9 years before jumping across into adult mental health services. But I'd worked before that in some not-for-profit organizations for people with developmental disabilities as well. With that said, many of the people that I have on our current team, they also have a history of working with people with developmental disabilities. So we're pretty acutely aware of the fact that some of the people that we have may have experienced a brain injury during the developmental period. We also recognize that many of our military personnel may have experienced brain injury during their deployment. And we know for a fact that there are many of the individuals. We did a little bit of a study. I'd have to go back and pull it out, but we took a look at the instances of brain injury among some of our the gentlemen and ladies that we had within the mental health units within our local Department of Corrections, and it was fairly high.
Well, that's a good segue into a question that has to do with veterans. So this particular participant today is a SSVF healthcare navigator. So working with veterans at West Corp, I think. The question is, do you see a lot of veterans in the Stabilization Center and Rose House? And then what veteran-specific issues do you come across, and do you engage any veteran-specific interventions?
So we're partnered with the Vet to Vet program, and their staff are in the Stabilization Center almost every day, working with the vets. And the issues we see are from homelessness to addiction to post-traumatic stress. I mean, there's a whole variety of issues that come in with them. And we have a great Vet to Vet program here in the county, and they've been really successful at getting people into the appropriate services.
Great.
We worked with our Vet to Vet program as well as some of the personnel within our vet centers, and I've at least one of my staff who just retired had a history of military service himself, and that really was very meaningful for some of the vets that we served within the community, to have someone that they felt was approachable and culturally competent from that perspective as well. I'm hopeful that we can recruit someone else back into an outreach position that has had a history of military service, because we do want to reflect the people that we work with.
Absolutely. And the person that had asked that question was pointing out the reason and why this was important is because 10% of the homeless population are veterans, and of these, 75% tend to experience issues with mental health and or substance use.
Yep.
So again, it's there's a high need,
Yep.
and to have that relationship with like the Vet to Vet program and peers and things that can be part of that engagement. I think it's extremely powerful.
Yeah, I want to add that the veterans are also becoming great employees because I hire them. So it's another bonus.
Oh, that's wonderful. That's wonderful. So there was a question related to the use of virtual, the virtual engagement, unfortunately with, COVID and the impact of the pandemic, it has shifted how we've done services and how we engage and connect. So what have been some of your, and I think, Mark, you were talking about even with the mobile assessment, that was probably even pre-pandemic or pre-COVID, because we know there's a lot of communities using technology with law enforcement out in the field to engage. So can you speak briefly about, how do you engage with having to use technology? Because some people find that a little clunky or less personal, or so how might people sort of, improve that or get over that?
I will tell you that the program that Steve and I work on together, the Crisis Stabilization Team, and our outreach and care coordination personnel within our department have been actively out in the field throughout the pandemic. We didn't stop, despite the fact that for a period of time, the city of New Rochelle was the epicenter of the COVID health crisis within the country for a period of time. We were actively engaging people within the community. We saw it as an even more critical time. It's interesting because some people have become very acclimated to using telehealth and telemedicine. I'm not sure if the people who are coming in to get the service are more acclimated than the clinicians. I think many of the clinicians have become very comfortable. But we saw the services that we provide, which are really a safety net service, they really needed to be done in person. We did use, we did start the mobile access at the beginning of the health pandemic because we had a conversation with the Police Chiefs Association, and they were expressed some valid concern about making sure that if they had somebody that they thought might need to go to the hospital, that if there were other options, we would want to explore them. So we assigned a combination of clinicians and peers to support each of the police departments. And we'll do that virtual assessment as well as telephone consultation to try to help people get connected to supports rather than go to the hospital, because we didn't want to expose people unnecessarily to COVID. We didn't want to expose officers to COVID. At the same time, if it turned out that somebody did have to go to the hospital, we wanted to have the conversation and have enough information that we could make as quick and smooth a transfer of custody over to the hospital, so that the person and the officer didn't spend any more time in the emergency department than they had to, so that people were getting connected to the appropriate care as quickly as possible. We had some people early on who expressed some significant concerns about doing things virtually. And one of the young ladies I can think of right off the bat, who was very apprehensive about doing things virtually, really she connected with it, and it really made a world of difference. I think that there are many different organizations that have taken the opportunity to create virtual groups for people, which have actually been quite productive. Our boots on the ground people kept going, but we did supplement it with some of the virtual.
Do you find even before COVID, but maybe even more so after that, by using virtual technology such as Zoom or Skype, were you able to connect with more people than before that technology was actually used out in the field? Do you see that it sort of made a shift in sort of the numbers of people that you've been able to reach and engage that maybe otherwise were not?
Yeah, it did
Go
for
ahead.
us. We were very surprised at the impact that it did make, and the number of people that were attending the virtual groups that we had been advertising. So we got a new population of different people that came to us through the COVID, and then the traditional folks that would come to us were there as well. So it's a large group.
Okay, that's great. Another question, and this has to do with the use of peers. Are there any nuanced approaches that you have incorporated to support peer staff in areas such as onboarding, training, supervision, professional development? And then can you also share the standardized training curriculums you have found to be most effective?
I can certainly share it. It's several pages, the training that we put our staff through. And then as far as the onboarding, we created a whole onboarding human resource policy and introduction to who we are, so that people that we do hire are, knowledgeable about what their expectations are. And then the support that we put into the organization is pretty incredible, where it's support groups within the organization, within different departments, plus knowing that our doors are always open for support as well.
Great. So once somebody is discharged from the crisis stabilization team, or perhaps too, this question may be related to the Rose House, are there any follow-up programs?
Constant follow-up, and that's one thing I really wanted to stress, and I wish I had stressed more of, is everything we do in our services is followed up by phone call, by face-to-face contact, by whatever the person feels they need from us. We provide it, and we don't just drop folks. So we will stick with folks to make sure that they're getting every available support that they want.
And I think we also addressed that when we said that we had to be assertive, and that it wasn't just a one and done, that we needed to make sure that people felt a level of confidence in working their recovery, as well as connecting to other traditional services that are out there in the community.
Great. So kind of again, sort of back with the stabilization team and the Rose House, how many people are able to stay at stabilization or at Rose House at a given time? Sort of what's your
Yeah.
capacity?
So it depends on the size of our houses. We have from a 3-bedroom house up to a 6-bedroom house in the 4 houses that we have. With COVID, it's cut in half right now, but normally it would be that many. And then for the stabilization center, we can serve 20 people at a time. So it's a constant rotation within the stabilization center. But right now with COVID, we can serve 9 people at a time.
Great. Back to the peer program, how long does it take to complete the peer certification program, and is renewal an easy process?
The renewal is easy. The time that it takes is really up to the individual person taking the courses. They open the courses a couple times a year from the state, and people can get them done in 6 to 8 months. Some have even done it quicker though, so it's really up to the individual.
Okay. So this question, it starts with, it's a challenge to ask a person to continue trying new medications when they have had negative side effects or medications have not been very effective. What is a good thing to say to them to help them stay invested in trying to find the right medication so they don't give up and just go off their medication altogether?
Yeah, that's really about support and education, and my staff are well versed in that, and my staff have also, as well as myself, experienced that struggling with the medication piece. There's alternatives to medication, and if they can get their psychiatrists or their practitioners to agree to attempt, other methods, other ways of dealing with things, not just with the traditional medications that are out there, they can be more successful. But I think what gives people hope and helps them to hang on is, again, that mutuality, my staff sharing that struggle is real, and validating that.
I've told this story before, but I will tell it again. At one point, one of our caseworkers and I went down to the 13th Annual Forensic Rights and Treatment Conference in Hershey, Pennsylvania, to talk about our alternative to incarceration program. And along with myself as an administrator and Homer as a case manager within the program, we brought one of the people who is a recipient of services, and he talked about his story and his experience with us. And when he got up to speak, he said, when I first met Mr. Thornton, who's a case manager, I thought it was going to be the same BS. I thought I was going to be told where I had to go to get treatment and what medication I was going to have to be on and when I was going to have to take the medication. But instead of that approach, Homer said to me, "What is it that you're concerned about, and how can we best help you?" And I said to him that I was concerned. I'd been diagnosed with an endocrine condition, and I didn't understand it. And I didn't even know what questions to ask my doctor. So Homer said that he didn't know what it was either. So the two of us went together down to the library to do a little bit of research on the computer about this endocrine condition. So that when we got to the end of the time that we were researching this, Homer said, if you feel comfortable asking the questions of your doctor, I'm good with that. If you want me there to help you, I'm good with that. By the time we got around to talking about medications for my mental illness, I trusted him. It wasn't the same thing. It wasn't somebody telling me what to do. It was somebody who listened to me and showed me care that I had not experienced in quite a long time. I felt like I had someone in my corner. I felt like I had a family member. And it was at that point that we could begin to talk about what medications and what psychiatrists, because I felt like I had somebody who was looking out for me. And I think that's important. And there's been other times with that same case manager, we had a gentleman who is on our ATI caseload, and he said, my goal is I want to get off my medication. And we supported him as the Medicaid. We developed kind of a contract with him, or a wellness plan with him. And when it turned out, we said to him, if we see X, Y, and Z, and he agreed, we see X, Y, and Z, then we may need to do something differently. But we negotiated with him, and we worked with him to get him off of all his medications. And for over a year, he did well without any kind of relapse at all. But we took a very person-centered approach, despite the fact that many of us on this call would say, well, that doesn't make sense. You're getting the person off their medication. I don't see medication as being a panacea. I think that medications are a tool within the toolbox. There are many ways to stay well, and there are many paths to recovery, and it doesn't always have to be medication.
Thank you for that story. That's pretty powerful. It sort of leads to another question, sort of along those lines of how Mr. Thornton approached things differently than what the individual was expecting. But the question comes and it's sort of kind of a twofold, but sort of how do you work to break down some of the barriers with people who have been either raised to not trust authority, or trust authority figures, law enforcement, courts, the service system, or where people have been engaged in the service system, but they've gone through several, case managers or caseworkers because people leave to go on to other jobs, and they, feel like they built a relationship and then the person left them. And so kind of, why should I do that again? So how might you address sort of the issues around, when someone doesn't trust easily or has been sort of hurt by, people leaving them in the system?
And I think that all relates back to our trauma-informed approach to care, and that we have to keep that as a reminder within everything that we do, is that many of the people that we work with have been hurt in many ways. And sometimes they have been inadvertently, sometimes even advertently, hurt in ways that our system currently operates. And I think that we can do better. So it's reassuring them that we recognize that, and holding their truth to be a valid truth, because many times it is. So what we would look to help that person build some natural supports and supports that would be meaningful for them. So we want to level the playing field to the best of our ability. And anytime we've got a service plan, it shouldn't be my service plan as a case manager. It's the person's plan. They should be offered a copy of that plan. They should be able to put that on their refrigerator, because it's not my plan, it's their plan. If it turns out that we have the opportunity to sit down and find out who they want to have involved in their treatment team. If they say, well, I would like my doctor, and I want you there, but I also want the guy that runs the local bodega because he helps me out. I want to invite the guy from the local bodega if it's possible, because we're not going to be there forever. There are people within the community that may be more natural supporters for that person in the long run.
Which leads to another good question looking at family and friends, and sort of an extension is, how do you utilize family or friends in terms of engagement with individuals? And then, how do you see families and friends as a positive or a strength to the process, or are there, barriers? And how might you address that?
It's really addressing the individual first to see if they want family and friends involved. I mean, it's it's their life, and we have a family therapist at the Stabilization Center who is good at working with families when they are all together and coming in. So we've taken the family seriously, and know that it can be a great help, but it can also be hurtful for people too. So you have to really walk the fine line, but really it's getting to know the person you're serving and seeing where they are with it.
Mm-hmm. So what are some ways to increase engagement with individuals who want to participate but find it very uncomfortable interacting with other people?
That we deal with that constantly. I mean, it's no matter what county we're in, the people there, they're not comfortable because there's not a lot of trust there. And so it's the patience and perseverance of us to listen to the person, to give them time to feel comfortable for us and with us, to have a stronger engagement, more successful engagement. It's not going to happen, in one visit. And you have to understand that it's going to take as much as that person needs to know that they're going to trust you that much.
So taking sort of those baby steps and being patient,
Yeah.
persistent, and supportive.
Yep.
Yeah. So let's talk about another population that you actually have some services toward from an outreach, but we haven't talked much about kids, but you do have your school outreach. So what are some strategies that are used to engage children, preteens, or teens that may be sort of, I'm going to do the air quote, be resistant or labeled that way, but kids that, how to engage children, preteens, and adolescents in services?
Once again, it's got to be something that is youth-centered, family-centered, but it also has to be multi-systemic approach, because there's not one system alone that has a responsibility for providing services for youth within the community. They're often impacted by social service systems, the Department of Probation, the education system, the mental health system. And many times what we see is that each of those systems are pulling the family and or the youth, the child, in different directions. So we need to make sure that it's a truly integrated approach involving all of the different parties. But at the core center of it, it's got to be based on the values of what the child and what the family want in order to move forward.
So we did speak some about COVID and the pandemic, but how would you frame the COVID affecting the way you worked with folks? So what kind of impact? What kind of shifts did you have to make?
One of the shifts that we made in the height of the pandemic for us, and I'm not certain that we're that far out of the height of the pandemic at this point, despite all of the vaccinations. But one of the things that we did early on is that we knew that there were some people who were terribly vulnerable, that didn't have even access, that they couldn't isolate themselves or quarantine themselves because they were living in the streets and living in encampments within the community. And we did some very, very assertive, proactive outreach with our police mental health outreach workers, with local law enforcement, with the Department of Social Services, to try to engage people and get them into places so that they would be safe. We brought masks. We bought food. We bought anything that we could bring along with us to try and engage the person. And we were very concerned about those people that we would consider traditionally vulnerable. We saw them as even more vulnerable during this time.
Yeah. So talking about another underserved population, so what might you be doing for the special needs of immigrants? This one participant talked about interviewing a Hispanic man who only completed 5th grade and couldn't speak English. And this participant sadly said she was not able to speak Spanish. He had a translator. So, we know there's several issues that impact immigrants, and one is fear of deportation or fear they're going to be turned into the authorities. And then again, there may be language, and as we talked some about cultural competency, there'll be cultural and ethnicity types of issues. So how might you work with or discuss some strategies for this particular population?
Well, one of the things that's been a real benefit to us with our crisis stabilization team for For the first year to 2 years, we had 3 out of 5 of the staff were bilingual. They were Spanish speaking. So that was a tremendous asset to us. One of our police mental health outreach workers is Spanish speaking as well. And so having staff available that can relate linguistically puts people at ease. In addition to that, many of the people that we work with are really connected to the faith-based organizations and in their churches, and having the opportunity to engage the person from a religious perspective, which also speaks to some of the understanding of mental illness and spirituality, and what mental illness means within that particular community and for that particular family and with that group of people. So it's complex, but not only if you use the resources that you have, if you have somebody who's bilingual, recognizing that there are many variations in Spanish speaking people, that people from Honduras may be different than people from Puerto Rico, they may be different than different beliefs in people from Mexico, but also using the religion as a gateway to help people access services as well can be very helpful.
I think that's an excellent point. They're such a part of one's natural support system. I think that's clearly something by engaging can help build that the rapport, the trust, and the sense of feeling safe. Because that's familiar to them. Wonderful. So I think we've got time for maybe one last question, and then we're going to work toward wrapping up. It's sort of the magic question that we tend to ask a lot of our presenters. So how did you get all these services into your community?
We snuck them in.
We knew it.
Yeah, it was I mean, literally the Rose House, when I first designed it, OMH didn't really know what it was funding. They just thought it was a neat idea, I guess. And when they finally realized it, that, you know, they embraced it, and now they're certifying there's respites all over New York now, which is great. And then the Stabilization Center, it's finding the right leader, and our county executive in Duchess County wanted this so badly. He went to the county legislation and pitched it, and they bought it and they funded it. So I think it's really telling the story and telling a logical story that makes sense, that's going to, you know, get people to buy into it. And that's what's gotten us to do a lot of unique things in our communities.
When I jumped the fence from working with people with developmental disabilities into adult mental health services, I came over to run our homeless outreach and community placement team, which was made up as 3 entities. There were a couple of workers from our office, there were a couple of workers from one of our peer organizations, Choice, and there were a couple of workers from New York Presbyterian Hospital. All of us made up that homeless outreach community placement team. I realized that some of the same people that we were working with were the same people that were being served through our mental health alternatives to incarceration program. So I took the opportunity to sit down with our deputy commissioner at the time and said to her, we can get a better bang for our buck if we're working in a coordinated fashion. So we began to take an inventory of what we had and where we were within the community. And I literally sat down with the sequential intercept map, and I said, okay, I've got this intercept 0. I've got, actually there was no 0 at the time. I've got this at intercept 1. I've got this at intercept 2, and mapped out where we were and where I wanted us to be within a 5-year period of time, and worked diligently with all of our partners within the community, whether it be the courts or the Department of Corrections or the probation department, where we've done some wonderful work stealing the ideas from the Schenectady County with their probation mental health peer support group. We've taken a piece of the puzzle all along the way to really fill out as many opportunities for diversion using that sequential intercept model as possible.
Thank you, Mark. That's very, very helpful from both you and Steve. So that's all the time we have for today. And I think just in summary, in terms of some key takeaways in engagement strategies. It has to do with the relationship building, letting people know they're not alone, that person-centered approach, helping people feel safe wherever they're at, that it's welcoming, that you welcome them to be a partner in the services, the paradigm shift that it's not their fault or that they're being just resistant, and to not give up. It's that persistence, patience, and support. So you have Mark and Steve's contact information. You will be getting these PowerPoints sent to you. So we really want to thank you so much for attending. We hope to see you at the future sessions of the Gaines Center's virtual learning community on early diversion, and we want to wish everybody a wonderful afternoon. Take care and be safe.